Over the past 3 years, the CMT has authorized investigation in about half, actually 51% of the time. And of those, 89% were closed after an investigation with no action taken against the practitioner. Only 11% of the investigations ended with a disciplinary action, and of those, less than 8% involved prescribing practices. So I wanted to let you know that there's a very small percentage of our complaints that are about prescribing, and of those, most of them get closed. If a complaint regards opioid prescribing for chronic non-cancer pain, our investigation will look into whether the practitioner followed the rules as set forth in the WAC, which we've given you a copy of if you'd like to take a look at that, and there's also a link to the WAC in your ebook. I'm going to go through some of those rules today just so that you can understand where we go and what we look at when we're doing our investigations. This thing is not working. Okay, there we go. The first thing we look at is for the inappropriate treatment of pain, which includes these situations. Sometimes a lack of understanding of pain management by the physician leads to inappropriate pain treatment, so we take a look at the physician in question. The practitioner may lack knowledge about pain management. However, the fear of investigation or sanctions by us may also lead to practitioners just not wanting to treat pain at all. But if you're prescribing controlled substances, including opioids, for legitimate medical purposes, and in the course of a professional practice, please don't fear action from us. I say that, but I'm a regulator, and I know the 3 words are "we're here to help you" are really not something that people understand, but we are here to help. During our investigation, we look at the entire treatment picture for the patient. What type of pain was the treatment addressing? The current pain rules really only address chronic non-cancer pain, but we are updating these rules to include acute, subacute, perioperative pain, and you'll hear more about that later. If the pain is chronic non-cancer, then the pain rules would apply, so we look at what was the nature and intensity of the pain and other medications prescribed. We look at what other health issues does the patient have, and how are these being impacted by the opioids? Are there any addiction issues? Was the patient pregnant? Are there any other factors we need to look into, such as the quality of life and functioning? This thing is really temperamental. The pain rules require a treatment plan, so we take a look at what that plan was for the patient in question. The rules require a written plan with stated objectives that is to be used to determine treatment success and includes any change in pain relief, change in physical or psychosocial functions, additional diagnostic evaluations, or other planned treatments. The physician shall look for compliance with the medication treatment plan. If the pain has decreased, has the quality of life or functioning increased? Is continuation of the treatment plan needed? And periodically review the prescription monitoring program for that patient. I need to not like this. Is there evidence of misuse? Are there other pharmaceuticals that are being used together that shouldn't be used together? We run the prescription monitoring program for that practitioner and look at their prescribing for this patient. And if we see any anomalies, such as prescribing over 120 MEDs. If there are high MED amounts, we dig a little further to see how prevalent that type of prescribing was for this particular physician. Now, how many of you believe that there's 120 MED dosage daily limit for opioids? Anybody? Good. Because there isn't. The 120 MED level is for consultation, not a required dosage. So if you prescribe over 100 MEDs per day, then there's a mandatory consultation threshold, and it's outlined in the WAC as well. And a consultation consists of at least one of the following: an office visit with the patient and a pain management specialist, or a telephone consult between the physician and a pain management specialist, or any consult between the physician and the pain management specialist regarding that patient's care if the physician is not a pain management specialist. So there are times when a consultation is not required under the rules. And that would be when the physician is a pain management specialist. And, or if the physician has completed within the last 2 years a minimum of 12 Category 1 CME on chronic pain management with at least 3 hours dedicated to long-acting opioids. There are other options that are listed in the WAC that I don't want to go through, but if you want to look at them, they're under 246-919-862. Also, you don't need a consultation if the patient is on a tapering schedule, or if the patient requires treatment for acute pain, so you up the dosage, but that's going to go back down to a lower dosage in a short period of time. Maybe. Okay. So we also look to see if there's any evidence of whether the treatment plan is working. A review of this plan by the physician is required every 6 months or annually if the patient is stable on 40 MEDs or less. We look to see have pain, function, or quality of life improved. If there are any evidence of adverse effects, evidence of misuse or diversion. Does the patient say, I lost my medications, the dog ate my medications were stolen, I left them at the pharmacy, all those kinds of things. Has a physician done urinalysis testing or other tests to determine if the medications are being taken appropriately? Overall, we investigate to see if the physician is following the pain rules if it's regarding chronic non-cancer pain, and we provide and is providing appropriate treatment. Now, we again use these rules as a tool in our investigations. We put all of the information that we find in an investigation into a report, and that report is given to the reviewing commission member, who is hopefully a pain management specialist or somebody that knows about pain. If they are not a pain management specialist, then we can provide an expert for that person to help that reviewing commission member review that case. And then the investigation report is presented by that commissioner to a panel of commissioners at each meeting. Tomorrow we're having a case review meeting here, and we divide the commission of 21 members into 2 panels. Panel A and Panel B, and so half of them are in Panel A and half are on the other panel. They present the case to the other commissioners, and they alone decide whether or not there is evidence to take disciplinary action, and if so, what action to take. Again, as I said, most of the cases after they're presented, after an investigation, are closed with no action taken. So that is something for food for thought for you, that we're not just out there doing a whole bunch of discipline, because we're really not. So those are the pain rules in about 5 minutes, and I know they're much more complex than that. And as we said earlier this week, we are going through a process to redo them. We're going to add other types of pain in here and prescribing habits for that, looking at all sorts of things. And if you would like to get involved in that, as Dr. Bunday said, it will make you feel really good about yourself to get involved. I encourage you to go onto our website, because we will be having meetings throughout the state over the next, 9 months, talking about pain rules and what we need to do for different types of pain. So I encourage you to do that.
Does this work?
Go down one.
Oh.
And you have to kind of point it somewhere. There you go.
Ah, okay. All right. So my name is Micah Matthews. I'm the Legislative and Deputy Director, and I'm going to be taking you through, stand up a little bit. I'll be taking you through a case study that some of you might be familiar. I'll do the law and order thing. Anything that looks like it's real life is not. This is just a model, sort of. So we're going to be looking at the case of the broken clicker. Somewhere Pain Center, we'll call it SPC for short. And basically, the demographics of this particular group was there were 5 to 10 locations around the state. Depending on who you talk to, anywhere between 8,000 and 25,000 patients were served per year. And they had 15 to 30 licensed practitioners covering MDs, DOs, PAs, and NPs. For recruitment, what they did is they focused on recently graduated mid-level practitioners who had zero pain management experience, with the incitement of signing bonuses, production incentives, and the promise of training in pain management by a board certified pain management specialist. I should note that didn't actually happen. They did get, some of them did get the money, but they didn't generally get the training. Consistency. They relied heavily on templated EMR entries. There was a standard process of every 30 days you had a visit, you had a mandatory urinalysis, you maybe got consulted about durable medical equipment prescription, you got your narcotics prescription, and then you would repeat. There didn't seem to be any noticeable indicators of a change in treatment plan based off of, say, aberrant UAs or diversion or anything like that. Which is why it all came down to really billing. There was a UA ordered every time, even though those are not required for the pain rules, and also you would notice that even if there were drugs not prescribed present or no drugs present in the UA at all, there was no change in the templated EMR language, there was no change in the treatment, they just kept going. It was a production line. And I think Dr. Bundy's reference of fast, cheap, or good really came into play here, and I'll get into that more in a moment. So as far as billing, just doing a little back of the napkin math, here's how it worked. So you had this screensaver that came on. You had a captive population who had fear of discharge, and they wanted to get their meds, they wanted to get their treatment. And so as part of that, just doing the UAs at $280 per UA times 8,000, you get 2.24 million a month. That's 26,880,000 per year in UAs alone. So there was a big business happening here. And by the way, that is the mid-level, that's the conservative number of patients they might have been treating. That is the mid-level amount of UAs they were billing to the healthcare authority alone. We don't have numbers on the Medicaid and how much they were billing, or Medicare, sorry. And then it comes down to the role of the medical director. The medical director was self-professed, recruited, designed all of the treatment protocols, supposedly reviewed all of the data that was coming back as far as any sort of mortality, and was over the entire practice and receiving the funding for that. But the question that we started to have were there other roles and responsibilities of a medical director? Did the medical director have a responsibility to step in and ensure that certain trainings would happen? If the medical director was notified of certain deaths, did they have a responsibility to react? And I'm going to pivot over to you, Dr. Trescott. Are there any particular roles of the medical director in this setting or others that you think are essential to point out?
Okay. I'm Claire Trescott. I'm a family physician. Is this on?
Yep.
And I should say I've been on the commission for about a year. And prior to coming on the commission, I spent about a decade being the medical director of primary care at Group Health. And while there, we established some standardized procedures for prescribing opioids for non-cancer pain. And also I've had a past history of working in addiction medicine. I'm past president of the Washington Society of Addiction Medicine, and so I've had and I still prescribe opiates. I worked 2 days ago in an urgent care and was writing prescriptions for opiates. And I just wanted to say that because we are getting together as a task force right now and going around, and I realized the last time I was at one of these meetings, I gave no one any idea why I was sitting at the table. So I just want to tell you, as soon as I joined the commission, I started to get lots of these cases, and began to see them. And I want to say one thing as a provider, I don't want us to be policemen. I don't want us to over-regulate at the state level. I want us to allow physicians to have autonomy and to practice good medicine. And I also would like to just say when we set up and so this does speak to the medical director role, because as a medical director in primary care, I had a lot of desire from the front lines to fix opiates. It caused so much chaos, so much dysfunction in the clinics that the doctors, the nurses, the pharmacists wanted to stop the screaming on Friday afternoons at the pharmacy line. And so I put together a group of people from many different parts of medicine, neurology, neurosurgery, pharmacy, lots of primary care physicians, nurses, et cetera. And we sat down with the goal of how do we become better clinicians? We don't want to be better policemen. What is the best practice of medicine in treating non-cancer pain with opioids? Can we define, because everybody was practicing at what they thought might be a good way to do it. And there was nowhere in the literature we could see that said, hey, this is how you do it, and if you do it this way, you're being a good physician. And that was our goal. So that's how we set those up. And I would say that I think my time on the commission, I see that same spirit here as we pick up a physician's chart or a medical director's work. Are they first causing no harm? Are they practicing good health care? Are they taking good care of their patients? Ultimately, that's what we're looking for. Are they practicing within a reasonable standard of care? So we aren't trying to nab everyone that steps across some imaginary line. We're really just trying to say, is the community safe? And as we look at some of these cases and look at some of the overdose deaths, some people had not been safe in this state and aren't safe the way the opiates were being prescribed. So we're trying to improve that. And last summer, the legislature got together and said we have to update the rules. So a number of us are on a task force. Alden Roberts has been to the meeting, Bob Small, Kathleen O'Connor, myself. We are going to meetings throughout the state to look at how can we improve or change the rules within the guidelines from the legislature. And I'm hoping if you have suggestions for us on what's good, bad, and broken about the rules, you'll get them back to us. In my everyday work right now, I tend to ask the other docs and that, what are we doing well? What would you fix in how we're managing it at this point? So I don't know if that answered your question or not, Micah, but.
Thank you. So in this experience, I'm just going to sort of outline the patient experience based off of the conversations we had with patients and practitioners who were at Somewhere Pain Center. So if you were there, you were 60% chance of being a Medicaid patient. You would come in every 30 days. You would pee in a cup. You would see a practitioner for 2 to 5 minutes. You might get counseled about the fact that you need durable medical equipment prescribed to you for that particular visit. You would go over your last urinalysis. You would get your prescription. You would pick it up and you would repeat. It was rare to see the same practitioner from one appointment to another. There was a constant rotation, so you had no one who was familiar with your case other than what was templated in the EMR. If you got into the waiting room and you were conscious enough, you got to see people who were nodding off, drooling, or passed out. And occasionally you were informed that you might have to have another test that sounded very expensive, something like perhaps genetic testing, and you were told in no uncertain terms that you had to get it, and yes, insurance would cover it. Little tip, it didn't. And when it didn't, you were ordered by the office manager to appeal the decision to get it covered by insurance, which again, it would be denied. There was a small percentage of genetic tests that were actually covered by insurance, and so they were able to make some money that way. UAs initially went through a lab that were actually owned by the medical director, and so there was a double dipping aspect there. So they were, as we previously talked about, they were generating between $2 to $5 million in Medicaid alone per month. Practitioners at the clinic informed us that it was common for the non-clinical durable medical equipment vendors to go through the EMR of the patient before their appointment and then send an email to the practitioner who was going to see that patient to tell them what they could bill Medicare or Medicaid for whatever DME that they thought would apply. So obviously there was a little bit of a question of, well, everything right there. And of course they would bill to the full amount Medicare and Medicaid would allow for. We already spoke about the captive population regarding the tests, but I would encourage you to look at the business logic this way. In order to access the higher dollar amount associated with UAs, DME, and other testing, you've got to have minimal contact with the practitioner. And so all that is required is to have them go in, see them, do the template of the EMR, and leave. Everything else is done by ancillary folks. And that's all you have to do to check the boxes for Medicaid and chronic pain rules, technically. All that it takes is 5 minutes, and you provide a production incentive to the practitioners. And at that point, you can probably see 15 patients an hour. So do the math, anywhere from 15 to 30 practitioners across the state, 15 patients an hour, you're making some serious cash. And Dr. Trescott, I was going to kick it over to you again. Do you have any comments on fast food medicine at this point?
Well, we aren't really talking about medicine here, I don't think. And I have seen some cases from this type of a setting. What is striking is that there were clinicians who were placed into this pretty dysfunctional system and actually practiced some good medicine. You could actually tell some were trying to do a good job. They didn't stay there that long. They tried to get good protocols in place and tried to have things done well, and it couldn't survive within this pretty toxic environment. And we are seeing a lot of this making lots of money off the UAs in a variety of places.
Yes, we are. And just so we're clear, it is illegal to own your own lab, send UAs to it, and get paid for it. That's called the Stark Law. Don't do it if you are. Public service announcement. Okay, so the warning signs. These were fairly typical of a pill mill. There were lines around the block. There were multiple non-substantiated at that time complaints. They were interested from other health-related agencies. There were high MEDs for the patients, polypharmacy, and that included the overdose triangle, or at least that's what our experts call it, where you're doing an opioid, a benzo, and a sleep aid. There were numerous patients that were on that combination, which led to the complaint, which we'll talk about in a moment. There was not much focus at all on non-opioid treatment. No consistent treating practitioners, as we mentioned. They were mostly young and inexperienced, with the exception of the medical director and one PA. The patients were not individually considered as reflected by the EMR templated use, and there was standard approach despite different clinical indicators. So really what I'm trying to emphasize there was not a focus on the patient or the function of the patient. There was simply a treatment of the assembly line. And the other warning sign is the explosion of prescription drugs available in the geographic areas near the clinics. There was just a hotbed of sales out there, really, is what happened. So the complaint, full disclosure, over about 6 years, the commission received numerous complaints about this particular practice and individual. And this is the full disclosure part, because of the fragmented nature of the system, because we received complaints where there were patients that were angry, they got discharged from the clinic, and the records showed that they had an aberrant UA. That was claimed to be the reason for the discharge. As we got further into it, what we found was it didn't matter if you had a positive or an on-track UA. If you were a problem patient, if you pushed back against what the clinic wanted, if they thought you were a problem, you got discharged. That was the true nature of the captive population. So what generated the actual investigation was a complaint from what's called the Medicaid Fraud Unit, or our favorite acronym, MFUCU, where it alleged that there were 65 deaths associated with this particular clinic over a 8-year period. Was that right? And while 65 divided by 8,000 doesn't sound like a huge amount, the fact is that this isn't comorbidity related. We think that these were opioid overdose, period. There were 2 cases that I can think of that were contributing factors, like a car accident or something, but these were almost all pure opioid related. We asked the Mufuku group to sort of narrow it down from 65. They came back with 18 that we focused on, and we got the records, the autopsy reports, and everything like that. And it ended up that we were able to substantiate enough evidence for action. The outcome was a little bit of a coordinated effort leading up to the actual action, which was a suspension of the medical director. There was involvement of the DEA, the Department of Justice, Healthcare Authority, the Attorney General, L&I, the Governor's Office, the Department of Health proper. Is anybody else? Yeah, us. So I mean, everybody was involved in this. The Office of the Insurance Commissioner, and so the folks that really took action in one fell swoop were Healthcare Authority, who took their action based off of what we did and terminated the core provider agreements for everyone at the clinics. The Office of the Insurance Commissioner helped with getting patients onto, as best that they could, other insurance plans. The DEA used our order as a platform to revoke the DEA registration, and they kind of had to start from scratch. And so The impact, I would say, is there was positive and negative impacts, I would say. That, as Dr. Lozier discussed this morning, it was a disaster in what they were doing. It was a disaster in the fact that it led to a spike in availability of prescription drugs, which Caleb Bantagreen, I'm sure, pivoted to say that it led to a spike in heroin use in King County alone. There was also the disaster of, it made us look at the fact that pain clinics aren't regulated. A lot of the coverage afterwards said, oh, the medical commission shut down a pain clinic or a series of pain clinics. The fact is they don't have a license. We don't have any power to do that. We took action on the license of the individual. The individual chose to close down the pain clinic and fire everyone there. That was his choice. And did anything change? You asked me, go drive down in Renton and take a look at where their old office was. Notice that they changed the name and they're operating. They have fewer patients. They've got a new medical director, but they've still got the same business partner, and they've still got the same venture capitalists who were able to raise funds and get them going again. The positive is that they have lower MEDs on their patients, and they've got a regional, world expert advising them on treatment protocols. So at the very least, you can say they're paying much closer attention to their patients. The investigations didn't take 6 to 8 years. Over a period of 6 to 8 years, we received about 10 complaints that came from various sources that ended up being non-substantiated. It was the Mafuku complaint that really generated more interest because that was, it was just more meaty, let's put it that way. Our investigation ended up taking about 12 to 18 months to get all the records and put together, get it to an expert witness who was from out of state but had familiarity with the UW pain program and even had some familiarity with the practitioner. And they were able to look at the records and clearly show the violation of the pain rules and violation of the standard of care in multiple instances. So typically our investigations, we've got a state rule that says we have to have our investigations done within 170 days. And while we approached the upper limit of that a little bit, we still were able to meet that particular performance measure. With respect to the medical director, non-punitive really wasn't an option. The medical director was given an opportunity to respond to our allegations. The response was delayed twice and came in on in fact, the day before we received our expert witness report on the evidence. And the response was contradicted by everything that we had evidence for. It just didn't hold up to any form of scrutiny. With respect to the other practitioners, I will say that part of the summary action was the commission filed complaints against everyone who had worked there as a licensed practitioner since 2013. The reason we chose 2013 is that was after the pain rules had come into effect, and it was just an abundance of caution to have all of those practitioners' work looked at by the various regulatory entities to make sure that nothing was missed. Yes,
Also, this is still going on, and things are still coming up. We still have, I think there's some deaths that probably weren't tied to it that are related. There was some really egregious behavior where people who were just getting out of a coma or an overdose placed right back on the same meds, those kind of things that made no sense. But there's not punitive action on all practitioners. As I said, as we get into the details, some of the practitioners were doing a good job and attempting to give good care. So, and there is normally CME and other suggestions in some of the actions that the commission takes.
I'm Barty Brigham. I'm one of the commissioners. I've been on, I don't even know.
6 years, something like that.
Something like that. I'm from Yakima, Washington, ER doc. I got to say, it's even a frustration among commissioners in terms of sometimes having maybe not all the tools we'd like to have when faced with a case. Due to the way the rules are set up, and by rules I mean the laws and whatnot in Washington State, is everything we do is discoverable. It's what they call a sunshine state, I guess is what they call it. I'm learning this terminology. It's not medical terminology. And so, there's a lot of times where we'll review a case, we'll say, this wasn't handled great. I'm not sure we want to like hit somebody with a 2x4 over this. We'd really like to be able to just call up and maybe suggest they take some CME or something like that. But we really don't have that option, because the minute we do that, that is disciplinary action. And so we're limited in terms of what we can and can't do. We either have to take action or not take action. We can't say, you know what, we understand you got caught up in this thing. We just want you to go out and get some CME and we'll all call it good. We can't do that. It's just not an option of ours. And that's a legislative decision, not a medical commission decision. So it's kind of an all or none. And we do have layers of action. We can go big, and for really egregious stuff, we can suspend licenses and whatnot. For less egregious, I can think of some of these type of cases we've had where we've reviewed a practitioner, we found maybe 20 examples of where they've taken care of chronic opiate or chronic pain patients. And it's just clear from looking at all of the records that this practitioner they need more training. It's just not safe to just let them continue doing what they're doing. And so you're kind of forced with saying, okay, we have to do something here. I feel bad because we see a lot of other medicine in the charts, and they handle the diabetes well, they're getting appropriate consultations, follow-ups. But when it comes to their care of opiates, they're really putting patients at risk in a big way. And in those cases, sometimes we do end up taking action. Those generally are focused around CME, writing papers, maybe making a presentation to a group of your peers, things like that. But it is disciplinary action. We really don't have the option of just asking someone to do CME without actually taking formal action.
So really what I come to is the patient impact. So Dr. Stanos talked a little bit about it. Dr. Lozier talked a little bit about it. The reality is some patients were able to get on to different pain management groups. Some moved on to heroin, and some very publicly took their lives. And that's a responsibility we have to live with. Was there an easy way to do this? Was there a right way to do it? I mean, there's a lot of armchair quarterbacking that can happen. Our approach in this case was fully recognizing that this was unprecedented in scale, and the only way to do it correctly was to be as transparent and as inclusive and reaching out to as many groups and organizations as possible. Behind the scenes, what you didn't know about was we were working with the various professional associations to get the word out, to get people to accept more patients, to get more referrals, to work with the Office of the Insurance Commissioner to get all of the medical directors of all the various health plans to move patients and accept more. This really was a little bit difficult, and I'll come back to the fragmented health system. The information we know about deaths and prescribing and everything comes from Medicaid. That was only 60% of the population. We don't know how many were Medicare. We don't know how many were cash. And that's just the nature of our health system. That also is what contributed to us not being able to recognize the pattern in the complaints we were getting. If we had had a bit more access to information, we probably could have seen this 5 years ago. But the fact is, that's just the nature of the system that we're in, and we have to do the best we can. So the conclusion is the best practices. Don't be somewhere and end up nowhere is really the lesson here. Emphasizing, treat the patient. You're going for function, you're going for quality of life. That's just job one. And if it takes longer to do it, I always like to use, it's Confluence now, but it used to be Wenatchee. Stu Fried over there gave a talk a couple of years ago about how it takes longer to treat these patients. You have to work harder, and they figured out pretty early on, you can't pay people on a production system in treating this group. You have to take the time with the patients and treat the patient. And it takes longer. That's just all there is to it. Follow the rules, know the exemptions. Melanie talked about those. One of the exemptions is to document that you could not reach a pain management specialist. That's one of the options available to you. Respond to the data. A lot of these UAs, as I said, were not indicating that they were taking their meds, or they were taking things that were not their meds. One of the tragic situations in this was there was a certified health practitioner who was found in an on-call room, a bathroom, overdosed by, they did that thing where they break up their pills and inject them. And this person was found at a hospital in the state. This person had a history of abuse, had track marks all up and down their arms, were known. And any cursory, just formality of a history would have found that. yet they still got their prescriptions, they still got their UAs, and they still got prescribed, and they still died. Use the resources available from the state. How many of you use the PMP regularly? How many of you know that there is a helpline for opioid prescribing that's sponsored by the Healthcare Authority? It's staffed by a pain management trained pharmacist. Dr. Jane Ballantyne is the one who helps write the treatment protocols for it. It's available for you to call anytime. There's Telepain at UW. Dr. Layton at WSU is also available for consults, and I'm hopeful that he will start up a service over on that side of the mountain. But there are more and more services that we're trying to get online, and those are just a few of them. And as always, practice saying no. That's one thing that we've been told repeatedly by practitioners that is hard, and no one really likes to do it, especially if someone has a good story or they look like they're in pain. They might be in pain, but sometimes the clinical answer is no. 1427 is what passed this last legislative session, and it's mercifully broad in what it tells us to do. It says create prescribing rules for opioids. So that can be acute through chronic, and it's for all prescribing practitioners. That's MDs and PAs, DOs, NPs, and anybody else that might be, PODs are on there, and pharmacy is on there because they get to hand it out. It authorizes prescriber reports from the PMP, which means report cards. And we don't know what that looks like yet, but I can assure you we are looking at it from the standpoint of what's going to be meaningful and not going to hit you with alert fatigue. We're mindful of that, and we want to make sure that that is not part of what happens. It also expands access. This is something that we haven't seen before, but we're starting to see a bigger trend of that to the PMP. So local health jurisdiction folks, local health officers, they are going to get access to this so they can, if there's an overdose that someone survives, they can actually get that report, look at the PMP, and take it to the prescribing practitioner and say, hey, did you know that your patient OD'd, and this is what you gave them. So just it's an opportunity to educate. So to your question about is there education, non-punitive things, this is what that is. We may have set prescribing criteria. We're not sure yet. Bear in mind that 1427, as broad as I told you it was, started out as a 7-day prescribing restriction for physicians and a 3-day prescribing restriction for dentists. That's what the original proposal was. So we were able to say, give us, the profession and the regulators, a chance to do this right, to do it with science, and they said yes. I assure you, if we don't do this right, the legislature will do it for us, and you won't like it. I talked about notification of patient overdose. It seems we're on the fence about requiring the use of the PMP, but I can assure you that is the sense of the legislation, of the legislators. If they don't think that people are using the PMP, regardless of if it's painful moderately or not, they're going to require it in a bill, and it'll probably be led by Paul Harris. He's got a personal connection with his sister. He told us the story during the hearing, and he said, my sister's dead because someone could not figure out how to use the PMP and see that she was doctor shopping. I don't care if it's hard for you, you're going to do it. So I assure you he will be the first out the gate with a mandating use of PMP bill if we don't do something about this that makes him happy. The PMP, when it was first around, it was funded by grants. And they were asking SAMHSA, DEA, DOJ for anything they could. The current, and since the beginning, administrator of the PMP was part-time. He basically was doing us a favor in the hopes that we could actually have a job for him, which that's a pretty tall ask for someone with a kid on the way. He's full-time now, and he actually has some staff because we keep on seeing the value of this program and getting funding. But it really does come down to, as he said, the vendor was resistant. My ideal solution would be to have somebody, pass a bill that would require EMRs to integrate the PMP in the workflow in order to have state certification and use in Washington State. But I'm one person, and I'm not the most popular person up on the hill sometimes. We pretty much have hit all of that. There's going to be more integration of the EHR with the Health Information Exchange. I know they're trying to beef that thing up, but I haven't been totally impressed with where we're going on that yet. It has so much potential, yet I feel like we're squandering it, and it's not in the public mind enough to, be a high priority issue. And I have more, it looks like. Okay, so as we said, there's 7 stakeholder meetings. The next one is in Spokane, October 19th. If you're in Spokane or not, go over there and provide your comment. They are working on trying to provide at least live monitoring via audio. It's a little bit harder to do live video monitoring, except you have people there who are doing like Facebook live feeds the whole time, so it's a little unsettling. The goal is to have 7 of them with the rules drafted by May 2018. Fall, we'll have the hearings, and then they have to be adopted by January 1, 2019. And I want to point this out. Adopted just means they've been adopted. It does not mean they are effective. So if we go back to 2011, 2012, the Medical Commission, when they did their pain rules, they adopted them in, if I remember right, January or February. They weren't effective until April or May. They wanted some time to be able to do some pre-education before they were effective, so everyone had a chance to know what they were and didn't run afoul of them. I can tell you that is entirely the intent of the group this year. They want to have at least 6 months of education before these rules are effective, so everyone knows what's going on. And that is apparently it.